Hello, everyone, and thanks for joining us for a special webinar on strategies to reduce diabetes-related amputations. I'm Adam Siglick with Biomedics, and I'm excited to introduce our first speaker for today's webinar, Dr. Krishna Jain. Dr. Jain is a big proponent of the office-based lab model for providing endovascular interventions, and is the Chief Medical Officer for the Amputation Prevention Experts Healthcare Network. Dr. Jain, I think it's great that you're leading off with some information regarding the prevalence of PAD. I'll let you take it away.
Thank you, Adam, and thank you everybody who has taken the time this evening to join. Let's talk about how to preserve limbs, and it takes a strategy really to save limbs. So what is the prevalence? The most recent data, which is kind of old actually, if you look at the days, goes back to 2004. We don't have current data. It shows that almost 6% of the US population 40 years or older has a low ABI, less than 0.9. which indicates presence of PAD or the peripheral arterial disease. The true prevalence of PAD is difficult to establish because more than half of the persons with low ABI are asymptomatic or have atypical symptoms. And because population screening studies that use a gold standard diagnostic tests are lacking. So if you look at that by the age group, the light green is men and the orange is women, as obviously you would expect. As the age grows up from age 40 to more than 80, the prevalence of PAD continues to go up. It is still, when you look at people in the age 60 and above, the men outnumber women in terms of percentage. If you look at people who are 50 plus and who are diabetics, 30% of them have PAD. 50-year-olds and older and smokers, 30% have PAD, and same thing with 70 years and above. So these are basically, as you can tell, are risk factors. And up to 20 million people in the US have PAD. So the risk factors, the strongest risk factor probably may be family history, which is sometimes undercounted. If you have bad genes, you can't change them, unfortunately. Hypertension, diabetes mellitus, smoking, dyslipidemia, and age above 60 years. All these are risk factors for peripheral arterial disease. So what are the indications for screening for peripheral arterial disease? The American College of Cardiology and the American Heart, in their perspective, patients at increased risk include adults 65 years or older, adults 50 years or older with risk factors of atherosclerosis or family history of PAD, what I just talked about, and adults younger than 50 years with diabetes and one other risk factor for atherosclerosis. These people should have screening for PAD. When you look at the Society for Vascular Surgery criteria, it is in adults at higher risk identified as age older than 70, current smoking or diabetes, abnormal pulse examination, or other established cardiovascular disease. So diabetes is a huge factor, and somebody's 50 and above and is a diabetic, they should absolutely get some sort of a screening. The American Diabetes Association, screening with ABI in patients with diabetes who are symptomatic or are asymptomatic and more than 50 years of age or have at least one of the risk factors, just like the American Heart. That includes smoking, hypertension, dyslipidemia, or duration of diabetes more than 10 years. How does the disease progress? In 2016, a systematic review found that over 5 years of follow-up, approximately 7% of patients with asymptomatic PAD developed intermittent claudication. And approximately 21% of these patients progressed to critical limb ischemia. That means they could lose their limb. So this disease is progressive. I always say, people talk about cancer, but atherosclerosis is worse than cancer because atherosclerosis you cannot cure, but cancer you can cure. Screening follow-up in a study, the conclusion was that a positive screening result for previously undetected lower extremity PAD was independently associated with short and long-term associated increases in mortality and major adverse cardiovascular events for individuals aged 65 years or older living in a large metropolitan area. This study was carried out in Las Vegas area. So toe and flow, and Dr. Lee Rogers actually is the first author on that, and Dave Armstrong, they are the two leaders in podiatry, in addition to other people on this paper. And they are the first ones. They talked about, they actually put it to a lot of prominence, toe and flow. That means you have to take care of the toes and you have to take care of the flows. So you need a partnership between podiatrists and vascular surgeons or vascular interventionalists now, because multiple specialties, including intervention radiology, intervention cardiology, and vascular surgeons take care of people with ischemic limbs. Dr. Rogers is our second speaker, and I'm sure he'll talk more about it. So what are the goals of a limb preservation center? You provide access to all services, timely care, long-term follow-up, and prevention. All these are important parts of preserving limbs. What are the challenges that one faces? If you go to any community in the country, these are the challenges faced by majority of the communities in the country. There's a delay in wound care consult and follow-up. Sometimes if you're not working closely with the podiatrist, it may take you a couple of months to get a patient seen for wound care. There's a delay in revascularization. On the other hand, if a podiatrist is seeing a patient, he wants a vascular surgeon to see the patient or an interventionalist, it may take a couple of weeks or longer for an appointment. Delay in getting appointed with other specialists and podiatrists. For example, if you need somebody to be seen by a cardiologist or infectious disease expert or a plastic surgeon, there'll be delay because you're not in the same network. Improper footwear, patients present with advanced PAD. How many times have you seen patients who show up to the office with a very advanced ulcer or a gangrenous toe? Management of risk factors. We don't have enough primary care doctors to manage risk factors, and supervised exercise. Very hard to do because people don't have sites. For example, in rural area, I practice in Kalamazoo, where we have surrounded by very large rural areas without any access to supervised exercise. So what is the current status? The current status is there are about 800 office-based labs. Nobody knows the exact numbers because I'm part of the office. I'm one of the founders of OEIS. And from our data, it looks like there may be about 800 office-based labs. There are more than 1,000 wound care centers. Most of these wound care centers are actually in the hospitals. There are very few centers, especially including HBO, outside the hospitals. The care is fragmented. All of us know that. To provide comprehensive care, multi-specialty approach is needed. In future, payment will be made for chronic disease management rather than episodic care. If the patients do poorly, you may not get as paid as well if you're in a healthcare network. Next. So what is a typical limb preservation center today? It is hospital-based, and you'll see a lot of ads. You go to any hospital and you go through their website and you'll see a limb preservation or limb salvage center heavily advertised. But if you go through the second or third page, there's not much depth in it. There's no office-based lab for endovascular procedures. It is extremely important. If you want to get timely care, office-based lab is a critical part of a limb preservation center. There is a delay in treatment because of scheduling conflicts. There's difficulty to get timely appointment with various specialists, and patients have to come multiple times to be seeing different specialists because the care is not coordinated. And usually these preservation centers are marketing oriented rather than patient oriented. So conditions, what are the main majority of the conditions that need to be treated in the arterial world is claudication, rest pain, ulcer, and gangrene. Rest pain, ulcer, and gangrene, of course, are critical care ischemia, which need to be addressed rather quickly. Claudication can be treated medically, and then ultimately, if the need be, patient may need revascularization. And venous disease is severely undertreated. There are patients with venous ulcers, insufficiency, and obstruction. These people need venous procedures. Obviously, diabetic ulcers need to be treated in the wound care center. And there are other entities like lymphedema, trauma, and smaller entities. So what are the services a limb preservation center should provide? Should be a multidisciplinary team, office-based endovascular lab, a wound clinic, a vascular non-invasive lab, easy access to the hospital if the patient needs to be hospitalized or needs to have some open surgery in the hospital, rehabilitation, and social services. Social services play a very important role because they can tell the patients how to get the treatment in various services. So what does the multidisciplinary team consist of? It's a vascular medicine clinic slash diabetic clinic, podiatry, an interventionalist, could be a vascular surgeon, intervention radiologist, or intervention cardiologist. Even if it is intervention cardiologist or intervention radiologist, you still need a vascular surgeon because if there's a complication of a procedure, the vascular surgeons can manage it, as well as the patient needs an open bypass or endarterectomy, they can do it. The cardiologist you need because if they have congestive heart failure, that needs to be managed. Infectious disease is extremely important, especially with diabetic foot ulcers, because they have usually complicated infections. And the sooner you treat the infection, the better the chance of saving the limb. Plastic surgeons for some flaps, etc. Orthopedic sometimes, some of the procedures, then a podiatrist may not be able to do both, but surgical podiatrists are very talented. They can do a lot of things. Rheumatologists, because sometimes they ulcer with the SLE and rheumatoid arthritis, etc. Neurologists and nephrologists. Next. So but in the multidisciplinary team, some people are essential. Without that, you really cannot have a limb preservation center. So you need a vascular surgeon for open and endovascular techniques. And if you don't have a vascular surgeon, then doing endovascular, they need an intervention cardiologist or intervention radiologist, but they can work together. Intervention cardiologists and intervention radiologists can partner with the vascular surgeon to provide comprehensive care. You absolutely need a podiatrist. You need a wound care specialist who may be a surgical podiatrist, or there may be some other people who take special interest in wound care, and an ID person, extremely important. So why an office-based endovascular lab? Why not the hospital-based cath lab? Because the timely endovascular intervention in an office-based lab, endovascular is critical. Because endovascular lab, most of them are managed by doctors, but so they're office-based, they're privately owned, and they can change the schedule and do the procedure the next day instead of going to the hospital scheduling system, which is extremely complicated and difficult. Hospitals are very cumbersome and expensive, as all of you know that. And the patient satisfaction is much greater in office-based lab. We published papers with a satisfaction rate of 98 to 99%. No hospital can claim that kind of patient satisfaction. Wound care centers that provide all modalities of wound treatment, including hyperbaric oxygen treatment, because there are certain patients who need HPO, especially with the diabetic feet ulcers who meet the criteria. Clinic patients should be followed by the wound center staff for consistency of treatment. What is the impact of wound care center? This was just presented at the Society of Vascular Surgery in June. So this is not a full article yet, but it came in Vascular Specialist, the local journal published every day at the society. And Dr. Chandra concluded by reiterating that the opening of an outpatient wound center was associated with a significant increase in peripheral vascular practice and a significant decrease in amputation rate. The emphasis is significant decrease in amputation rate. What is it? Go ahead. Next. So HPO treatment indications are 15 indications by CMS. I only pulled out one of those. These are approved by CMS, which pay for the treatment on inpatient or on outpatient basis. These are diabetic wound care of the lower extremities in patients who meet the following 3 criteria. Patient has type 1 or 2 diabetes, has a lower extremity wound that is due to diabetes. Patient has a wound classified as Wagner grade 3 or higher, and patient has failed an adequate course of standard wound therapy. So you need to have these criteria. If they meet the criteria, then they can have HBO treatment with good results. A vascular medicine clinic is important because they need to have the risk factors managed. But when we talk about preservation, I talk about limb preservation, not just limb salvage. Limb preservation means also managing prophylactically the risk factors so that they don't get into critical limb ischemia. So you need to manage their diabetes before treatment or after treatment, hypertension, hypercholesterolemia, nicotine addiction, obesity. They need to be put into an exercise program if they have coagulation disorders and other smaller risk factors. Rehabilitation sometimes is very important. So suppose somebody ends up with a transmetatarsal amputation or loses their big toe, they need physical therapy, occupation therapy. In case they end up with a major amputation, they need proper prosthesis and they need both PT and OT. So what is the advanced therapy? Advanced therapy is endovascular procedures, angioplasty, stent, atherectomy, and new treatment coming out is shockwave for calcified arteries, open procedures, bypass, endarterectomy. Then we do hybrid procedures. We do bypass along with an endovascular procedures, foot sparing amputations. I'm sure Dr. Rogers may talk more about it. Reconstruction of deformed foot, grafting, skin grafting, HBO, thrombolysis, gene therapy, and the venous procedures. About 30% of the patients coming to the wound care centers have venous disease, so they may need a venous ablation, microphlebectomy, or dilatation and stenting of the arteries. So we published this paper a few years ago from our experience in Kalamazoo, from our OBL, which actually showed how safely the care can be provided in our office-based lab. So this is data from for arterial intervention for the number one, the one on the top is our group, and the 4 other groups who had published data on arterial intervention. If you look at 1,537 procedures done, there was 6% complication rate, only 0.6% transfer to hospital, which is quite phenomenal, 0.6%. 30-day mortality was 1 patient out of these 1,537 procedures died, but it was not due to a procedure-related mortality. So you can see how safe the care is in an office-based endovascular lab. So multimodality approach includes the medical management, percutaneous revascularization, open vascular procedures, orthotic care, surgical care of the ulcer, podiatric procedures, orthopedic procedures, plastic procedures, hyperbaric treatment. It takes all these specialists to take care of the patients. So what is the future? Future of limb preservation is in a dynamic market. The centers that innovate will succeed and do very well. To improve care and receive appropriate reimbursement, a comprehensive approach is required for limb preservation. Gone are the days when only one person can do it all. You need all partners to work together to make the patient better. And we have to move from the concept of managing critical limb ischemia to total management of the patient that includes participation by multiple specialties using different modalities. It's extremely critical to create a multi-specialty group for limb preservation. And this is my final slide. And I call it revascularization wound care. This is a twin tower in Kuala Lumpur. And as you can see this beautifully, there's a bridge between the 2 towers. And we have a bridge between the wound care specialists and people who do revascularization. We can preserve a lot of limbs. Thank you for listening.
Thank you, Dr. Jain, for that valuable information. At this time, if anyone has any questions you'd like to ask the speakers, we'll be fielding questions at the end. So please enter them clicking on the Q&A button at the bottom of your screen, and we'll try to get through all of them at the end. We're going to spend a little more time on PAD detection, highlighting our technology as one tool you can use in your practice to help prevent amputation and optimize patient outcomes in these models. At this time, I'd like to introduce our next speaker, Lee Rogers. Dr. Rogers is the Chief of Podiatry at the University of Texas Health Science Center at San Antonio and serves as the President of the American Board of Podiatric Medicine. He's written many papers and articles on limb salvage and has delivered many lectures on the topic worldwide.
Thanks, Adam. Really appreciate it, and I appreciate being here with Dr. Jain. And it's hard to follow him, and so I'll cut some of the slides that I have, because he's really covered the multimodal or multidisciplinary approach to the diabetic foot and preventing amputations very well. So what I want to talk about really is the clinical practice guidelines and how those clinical practice guidelines can adapt your practice so that you can provide the best evidence-based care for the patients that you're seeing in your practice. So we're going to cover 2 clinical practice guidelines that I find very important. One is the Global Vascular Guidelines, and the other is from the International Working Group on the Diabetic Foot. And both of these are available open access online at both journals' websites. And if you need to get them in PDF form, you can email me afterwards. I'm happy to give them to you. So the first thing I want you to understand is that the diabetic foot is actually a syndrome. It's not a single entity. And there are lots of things that go into the diabetic foot syndrome. So you have peripheral artery disease, which is what we're really covering today, abscesses, gangrene, foot deformities, Charcot foot neuropathy, foot ulcers, what used to be called critical limb ischemia, which is now called chronic limb-threatening ischemia, amputation and cellulitis. All of these come together to make up the diabetic foot syndrome. So it's not just a single entity, it is a conglomeration of disease entities that make up the syndrome. The diabetic foot ulcer alone is a very expensive disease. It's an expensive complication of diabetes. and this data is old, but the multiplier is still the same. So when we look at this data, which was published in 1999, we see that those who were age and disease matched, had diabetes, had comorbidities, but did not have a foot ulcer, they spent on average $5,000 a year on their healthcare. And those that had a foot ulcer had an increase by about 5 times in what it costs to take care of them over the course of a year. But where are these costs? So if you look at it, I mean, I know that probably most of you listening, you're thinking, well, I'm not the one that's receiving all of this reimbursement. Well, in fact, you're not, no, because most of this cost, about 3/4 of it, is occurring on the inpatient side, and only 1/4 of it is occurring on the outpatient side. Now, some of this cost is due to the length of stay, and we know this is Medicare discharge data. And I know it's probably hard to read, so I'll just go over it briefly for you. But these are the average number of days that somebody with Medicare, so obviously that age group, spends in the hospital for any of these diagnoses that are related to diabetes. They must first have diabetes, and then if they have DKA or ischemic heart disease, they spend about 3.5 days. If they have congestive heart failure or stroke, they spend about 5 days in the hospital. But if they have a diabetic foot ulcer, they spend 7.7 days in the hospital. And if they get any level of amputation, the average length of stay is 9.6 days. And this attributes to the overall cost. And that's not the end of the cost, because we know that those who have diabetic foot ulcers have a very high recurrence rate. And this is a meta-analysis of several studies, which the longest study goes out to 5 years. And you can see here, this is the percent of patients that have an ulcer recurrence. And all the studies went out at least 1 year. So of course, you can see somewhere between 30 and 40% of those have an ulcer recurrence over a year. If you go all the way out to 2 years, around 50%, at 3 years, about 60%. And if you're lucky enough to make it to 5 years, 70 to 80% ulcer recurrence. So Dr. Jain talked about the multimodal approach. We wrote about this too, the multidisciplinary approach, and we put this in the global vascular guidelines on essentially like how to create a center of excellence for amputation prevention. And we put this in context of the team, the setting, the components of what you need, and how the team's going to function. And there have been dozens of peer-reviewed studies that favor a team approach to limb salvage. So, and this isn't just podiatry and vascular or vascular interventionalists. This is the entire team. But you can see here, this is a forest plot. So how you read this is that the anything to the left of the line favors a multidisciplinary approach. Anything to the right of the line shows that it didn't make any difference. So what we see here is that most of these studies favor a multidisciplinary approach, including the standard deviations, which are the line that goes across there. And so the standard deviation, even in most of these studies, stays all the way to the left of the line, meaning that these are highly significant for favoring a multidisciplinary approach. So Dr. Jain went over all of the different disciplines that would be necessary to include in your approach, you know, but I do it a little bit differently here, because I go through the different disease or parts of the syndrome that you might need, like infection, ischemia, wound care, surgery, and then rehabilitation, and kind of break up those same specialties that Dr. Jain talked about, but break them up into where they're needed in this multidisciplinary approach, and almost really based by severity. So of course, infection comes before ischemia. We'll get into that in a few moments. And then obviously we're focused on wound care, surgery, and rehabilitation. So we wrote about the toe and flow model, and it was published it was actually co-published we got a joint publication in the Journal of Vascular Surgery and the Journal of the American Podiatric Medical Association. We divided up these skill sets and resources almost like you have levels of trauma centers. So you got level 1, 2, and 3 trauma centers, and we have basic, intermediate, and center of excellence level care. And also this paper is open access on both JVS and JAPMA's website. But again, if you need it, feel free to email me. Happy to send you the PDF. So now let's talk a little bit about the guidelines and how they go into your everyday practice. First guideline that I want to talk about is the International Working Group on the Diabetic Foot Guidelines. All of these guidelines are available on that. You can see they cover all the different parts of the diabetic foot. We're going to just cover peripheral artery disease today, but they're all available on the IWGDF Guidelines.org website. They were all published and they're all available open access now on this. But they do have a very global view. So you may not be able to take everything out of the guideline and turn it into your daily practice, but we're going to go into where that might apply to you. So let's go into some of the recommendations that were put into the IWGDF guidelines. And I'm just going to cover some of the real highlights here. There's several recommendations, but let's go over ones that are going to make a difference probably in your everyday practice. Number 1, examine the feet of all patients with diabetes annually for the presence of PAD, even in the absence of foot ulceration. And at minimum, this should include taking a relevant history, palpating foot pulses. Then number 3 here, as clinical examination does not reliably exclude PAD in most people with diabetes and a foot ulcer, evaluate the pedal Doppler arterial waveforms in combination with ankle systolic pressure and systolic ankle brachial index, ABI, or the TBI, and that no single modality has been shown to be optimal, and there's no definite threshold above which PAD can be reliably excluded. However, PAD is less likely in a diagnosis with the presence of an ABI between 0.9 and 1.3, and with a toe brachial index of greater than 0.75, and if you have triphasic pedal Doppler waveforms. And that's what's really important, combining the waveforms with the ABI or the TBI. Then number 8 here, which I think is important, always consider revascularization in a patient with a diabetic foot ulcer and PAD, irrespective of the results of your bedside tests when the ulcer is not healing within 4 to 6 weeks, despite your optimal management. So number 14 here, ensure that after revascularization in a patient with a diabetic foot ulcer, the patient is treated by a multidisciplinary team as part of a comprehensive care plan. 17, provide intensive cardiovascular risk management for any patient with diabetes and an ischemic foot ulcer, including support for cessation of smoking, treatment of hypertension, control of glycemia, and treatment with a statin drug, as well as low-dose clopidogrel or aspirin. Now, this was published, as you know, in 2019. This predates a lot of the data that came out, the COMPASS and the Voyager trials, where we're looking at some of the newer DOACs and the impact that they have on cardiovascular risk reduction. So that data is probably even stronger, led the ADA to issue a statement saying that we should consider DOACs as a first-line treatment in patients with PAD, not only for reduction in the risk of amputation, but also for reduction in the risk of cardiovascular events. So we published in the Journal of the American Podiatric Medical Association this kind of synopsis of the global vascular guidelines, really geared toward podiatrists, because the entire global vascular guidelines is about 60 pages long and contains a lot that is geared toward vascular surgeons. And so this is really about what a lower extremity specialist or a podiatrist should be looking at, and how the global vascular guidelines impact you. Next. So there was a nomenclature change recommended by the Global Vascular Guidelines. You're probably familiar with what used to be called critical limb ischemia. That is now recommended to be changed to chronic limb-threatening ischemia, because there really is no threshold that you can define as critical limb ischemia. So there's nothing that's, okay, below this is fine, or above this is critical limb ischemia. And so it really takes into account that this is a clinical syndrome, and it's a more severe stage of PAD. So you could have PAD, you don't necessarily have CLTI, but what CLTI is PAD in combination with rest pain, lower limb ulceration, or gangrene, essentially tissue loss. So how do you diagnose PAD and CLTI? Well, you have to understand first that the clinical signs and symptoms are often unreliable. Those with neuropathy don't have intermittent claudication, typical of people without neuropathy, and may be either just purely genetic, or smokers might have. So instead, we have to rely more on non-invasive hemodynamic tests, things like ABI, TBI, and PVR. So understanding again that CLTI is PAD plus rest pain, ulceration, or gangrene, and it is most important to have a high index of suspicion and know the statistics. So another question that's asked is, who should be referred to a specialist for further evaluation and treatment of CLTI? Well, all patients with suspected CLTI should be referred urgently to a vascular specialist. And we have to understand, just as Dr. Jain said, time is tissue, delay is the largest contributing factor to limb loss. Nowhere else in the body would we tolerate ischemia. If you had ischemic myocardium, ischemic bowel, you'd be in the cath lab immediately, but somehow we still tolerate ischemia in the lower extremity. I think some of it's due to apathy. Other is due to neuropathy, where patients aren't complaining of excruciating pain. So, we think it's okay to just have them seen in 2 weeks or 3 weeks, which is really inappropriate. So another question, which should be treated first, infection or ischemia? Well, we know abscesses, wet gangrene, or gas gangrene, they are limb and life-threatening surgical emergencies. If infection and ischemia are present, infection should be managed urgently, and revascularization considered once the infection is under control, once you gain source control. You don't need any vascular clearance to take somebody to the operating room for a surgical infection emergency. So the SVS and APMA came out with their own guideline, or this actually predated this was published in 2016, so this predated the Global Vascular Guidelines, which were 2019. But I did want to point out a couple of things that were important here. Maybe it'll come up if you click advance. I think I had here it comes. All right, so a couple of important things here is that all patients with diabetes should have an ankle brachial index measurement performed when they reach 50 years of age. And then recommendation number 3 here, which is also important. Patients with diabetic foot ulcers who have PAD, they recommend revascularization by either surgical bypass or endovascular therapy. So how does all of this come into your daily practice? Well, this is where you can take clinical practice guidelines and turn them into a practice pathway, something you're going to work on in your hospital or in your clinic. It's always better if you write it down. And I find that, and this is one thing that Dr. David Armstrong and Larry Lavery and I helped develop for Apex with a partner in Saudi Arabia. And so we adapted the clinical practice guidelines to their situation. And you can see here, and this is also hard to read, but you have a patient that comes in with a clinical diagnosis. They have lower extremity ulcer, gangrene, and so we first start out with laboratory diagnoses, and that includes non-invasive vascular studies. Then we move on to imaging, which if these are positive, you're going to go on to angiography. that include the ankle and the foot. And then the goal is really to restore inline perfusion to the foot. This is done by either endovascular or open bypass. And you either have adequate or inadequate results. So if you have adequate results, you proceed over to wound care. If you have inadequate results, then you consider revision or alternatives. If it's still unsuccessful, then maybe you consider amputation or what we call sometimes wound hospice, where you're just trying to prevent infection and move on. So clinical practice pathways then should generate policies and procedures. And policies and procedures are very common for hospitals. If you work in a hospital or in a wound care center, you're probably used to seeing policies and procedures, or maybe you haven't seen them, but they exist and they're there and should be followed. And so this is an example of something that we help to create about non-invasive vascular studies. And this is just an example of one, but it's an example that's pertinent to the current discussion, because we create policies and procedures that are for infections or for Charcot foot or for imaging or for wound dressings, all of these different things. But this one deals with non-invasive vascular studies. And so you create these policies and procedures that are based on the current evidence, but things are going to be followed in the clinic and what to do if they're positive. Next. So we have to understand, as I mentioned before, that the physical exam is often insufficient for somebody with diabetes and suspected PAD. A pulse examination is unreliable, and there's been several studies that have found that even in the presence of palpable pedal pulses, there can still be pretty significant PAD. And so we need to perform a diagnostic assessment for PAD. And this includes things like non-invasive vascular studies. Next. So one of the things that we use, and I've actually used PADnet. They've been a great partner of mine personally and in my clinical practice since I first got out of my fellowship with David Armstrong. And I went to Des Moines, Iowa. I was working in Broadlawns Medical Center in the county hospital. And that's where I first got experience with PADnet. And it's a non-invasive vascular diagnostic device. It can help diagnose PAD. It's pretty simple that the entire staff can be trained to use, and the technology is reimbursed both for it depends where you're using this. So if you're using it in your private office, it can be reimbursed the entire both the cost of the test itself and the reading, or if you're doing it in the hospital, you can split those up. So how does the PAD testing work with PADnet? Well, what we get is an ankle brachial index. So we take there's 4 cuffs, and they get both the systolic pressure of both brachial arteries and the pedal arteries, and what we're getting is an index of the lower extremity or ankle arteries over the brachial arteries, and then that creates your index. And that index should be as close to 1 as possible or slightly above. So how this becomes even more important is understanding that the ankle brachial index is sometimes falsely elevated or could even be falsely normal, which is even worse in patients with diabetes because of calcification. So it's important to also check further distal arteries, and this is done with the toe brachial index, where you take the same calculation, but instead of the ankle systolic pressure, using the toe systolic pressure that's done with a smaller cuff on the toe, and these smaller vessels are less susceptible to calcification. Not never. I mean, sometimes you can see foot x-rays and you can see calcification go all the way out in the small arteries. But if you're looking at numbers and you're looking at an ABI or a TBI, and then you compare that and consider the pulsed volume recording, and this gives you a graph, and you can see those graphs over here on the right. And if you can see that you either have, really what people are saying now, we used to say triphasic, but it's really multiphasic. It's hard sometimes to see all three waveforms, but you want to see multiphasic flow versus monophasic flow. If you see monophasic flow, then you realize that, or you should, that the indices cannot really be relied upon in that case. But where the benefit is if you see multiphasic flow, then you can rely upon the indices. So we know that there are advantages to using coordinated care. In one study that was conducted by Sutter Health, patients with multiple chronic conditions receiving coordinated care services compared to those who did not receive coordinated care, 24% had fewer visits to specialists, lower ED visits, fewer acute hospitalizations by 40%, and then fewer outpatient visits at hospitals. So coordinated care, whether we're talking about CHF or we're talking about PAD and wound care and diabetic foot ulcers, can lead to better outcomes and reduced costs. So I really appreciate your time today. I want to conclude by inviting everybody to a meeting that we host here in San Antonio called the Great Debates and Updates in the Diabetic Foot, which is gdudiabeticfoot.com. And this is a meeting that is hosted by the University of Texas down here in San Antonio. And you can see the agenda when you look at it, but we really focus a lot on the multidisciplinary care of the diabetic foot. And we of course, include a lot of information on PAD and how to create your team so that you can go back on Monday morning and change your practice and hopefully make a difference in your patients' lives and save limbs. I'll turn it over to you, Adam.
Thank you for the information, Dr. Rogers. We'd like to thank both of our speakers today. And it looks like we have some questions, but in regards to the PADnet reimbursement, PADnet's reimbursed at the 93922, 93923, and 93924. If there's any questions regarding the reimbursement, please reach out. I'm going to start reading out some questions now. This is a two-part question. If a podiatrist is scheduled to perform a surgical procedure on a patient at risk for PAD, is it appropriate for them to perform a diagnostic study in their office? And would a vascular specialist be okay with interpreting the results remotely if possible?
Should I answer that? The answer is yes. It is totally appropriate and actually should be done to do that. And as a vascular surgeon, we used to retest for some of the, not the podiatrists, but some of the primary care doctors had PADnet in their office, and we used to interpret for them. That's perfectly legitimate, should be done actually in a podiatrist's office, and vascular surgeon should partner with that. Sometimes if it's not the vascular surgeon reading in your community, it could be intervention radiologists, or sometimes intervention cardiologists are reading those tests too. And they can bill for the professional component, while the office, the podiatrist's office can bill for the technical component. That's totally legal.
Next question. Thank you for the insights shared by Dr. Jain and Dr. Roger. What percentage of new diabetic patients are systematically screened for DFIs, diabetic neuropathies, and when does intervention start?
Lee, you want to answer that?
I don't know if DFI means, I use DFI, I say that means diabetic foot infection to me, but is it, maybe they mean diabetic foot ischemia in this case, because you don't really screen for infection. So I mean, I guess I'll answer it in the realm of ischemia. So really we screen, there's difference between screening and diagnostic, right? So in somebody, the ADA has come out with guidelines on screening, and so is the SVS, so is the APMA. Screening means that they just have diabetes and they don't have any other problems, not a single symptom. That would be screening, right? And so Medicare does not pay for screening tests. And so you don't really want to do widespread screening. However, if there is a single symptom that could be attributed to PAD, even lower extremity edema, even certainly an ulcer would qualify somebody to receive a test. those are no longer screening tests. Those are now diagnostics. And you're using the test to diagnose PAD. So 100% of those with symptoms should be undergoing some non-invasive study for PAD. And if positive, then referred on for management from a specialist.
Yeah, so the thing is also there used to be, and there still is, and the community-wide screening that people will go to churches and do screening for for PAD. So that what Dr. Rogers just said is not covered by anybody, literally, unless it's somebody, patients pay out of pocket. But when the patients have risk factors and they have no palpable pulses or suspected of peripheral arterial disease, that becomes diagnostic. And at that point, you can, your PADnet could be your first test, actually, and if that shows disease, then you could possibly go to ultrasound test or to find where the blockages are, or you could identify what the patient's symptoms are and then treat them accordingly. So, but the generalized screening that is done at the health fair and all that is not covered by any insurance company, including Medicare.
Okay, thank you. Another question, as a podiatrist, is it appropriate for me to be performing ABI testings in the office rather than referring to a vascular doctor?
I can answer that. Absolutely, you should do it in the office. There's a shortage of vascular surgeons around the country. And one of the things I talked about in my talk was delay in care. And if you can do some of the preliminary work in your office, I would not recommend that you do a more extensive imaging of the vessels, etc. But to get the preliminary workup is totally fine. And vascular surgeons, we used to appreciate it when we got patients from practices who already knew that the patient's ankle break index 0.75. So then when we're seeing them, we knew how to go to the next stop.
And one final question, why would one open up their own OBL or wound care center? And what are the benefits in doing so now?
Well, absolutely.
Let me, Dr. Jain, I just want to, sorry, I was on mute. I want to say something real quick on that other last question, which is, it's imperative for podiatrists to do this type of testing in their office. And actually, I say not refer to the vascular surgeon for these types of diagnostic testing, these non-invasive diagnostic testing, because one of the things you said is that vascular surgeons are very busy, and that's true. There's also a delay when you send them there. But if you're going to perform any type of procedure, even, I mean, this sounds ridiculous, but it's true. Even toenail debridement, I mean, certainly. Nail avulsions. I've seen so many cases where I've been an expert in a case, a lawsuit where somebody had not done non-invasive studies on somebody and underwent something as simple as a toenail avulsion, turned into gangrene, and even lost a leg in some of these cases. So it's imperative that you do it. And two, if you're going to have a good partnership with a vascular specialist, vascular surgeon, interventionist, whatever, the best partnership you can have is one of trust. And so when I send a patient to my vascular surgeon here at UT, they know, I call them on the phone and I say, okay, this person needs to be seen. They pretty much book them for an angiogram right then. They know if I'm sending them somebody that they need an angiogram. And so that type of relationship really works well. It doesn't clog up the vascular clinic. I can do it right here in my own clinic and really save the patient a lot of runaround and save a lot of delay.
Yeah, I echo everything Lee just said. Because especially again going to the medical legal arena, I have defended doctors just for that reason. So we used to get a lot of patients to be checked out if they were going to have a bunionectomy or whatever, and they had no pulse or abnormal ABI or abnormal waveforms. We would get those patients in advance. Now, to answer the question about OBL and wound care center, I talked a little bit about in my talk. There is, for example, if you send a patient to me today to be seen with a foot ulcer or a gangrenous toe, and I do an ultrasound in my office and I find that the patient has superficial femoral artery occlusion, kid me not, it will take me at least a couple of weeks to get it done to it, put it through the hospital system to revascularize that patient, number one. Number two, if I don't have a wound care center in my place, then to get an appointment in the wound care center, there may be one or two in the town. It may take a couple of weeks to get the patient seen. Now, if you have both access to the OBL or a wound care center, that is immediate. You know, in the sense, the immediate wound care center, they basically get seen right away or the next day for managing their wound. So we are now managing their wound, taking care of the infection, et cetera, whatever debridement needs to be done. And now, if the patient has ischemia on top of that, then for example, in my own practice, I would see a patient on Monday. I always kept my clinic was on Monday. I would always keep an open spot on Tuesday. I would see a patient with a gangrenous toe on Monday morning, do an ultrasound in the office the same day, and find out the patient has whatever blockages they have. They go to the lab to get their blood work done, get their creatinine, PT, PTT, BUN done to make sure they're adequate candidates. And my open spot Tuesday morning, I would take them to the OBL, which are group controlled because we owned it. And then we would revascularize the leg the next day. And subsequently, these patients in 4 to 5 to 6 weeks, we'd come back. You know, obviously we'll continue to follow them with a gangrenous tip of the toe, which could basically, I could debride in the office. So think about it, the same patient now, if you don't have an OBL or a wound care center, trying to get a wound care center appointment somewhere. And number two, now to put through the hospital system where you know, the operating room, the cath labs, all these places have 2 to 3 to 4 weeks delay. I mean, there are many people looking for the same time in the cath lab or the operating room. The other thing that people don't recognize, that we did a study actually internally in the hospital when I was practicing, is that when a patient comes into a hospital system in an outpatient basis, patient has 35 touches. That means the patient sees 35 people by the time they come in and go home. In OBL, we had 9 touches. That means there were 9 people in the office. So think about, if you are a patient, you have a patient, and you are seen by 35 people versus 9 people, you can develop relationship with that, and you come back, see the same people. Is a phenomenal care for the patients. So in my personal view, there's no better way of taking care of these patients with significantly ischemia, but with a combination of wound care center and an OBL. Adam, any more questions?
You mentioned, you know, working with the right vascular specialist. In your experience, what was the best way to find or collaborate the best vascular specialist to work with in your experience?
Yeah, so I mean, I think that you have to, it's going to be different everywhere you are. So if you're in a big university setting, it's going to be a lot easier. Somebody's probably right across the hall from you, right, you know, on another floor. But if you're like most people in a group or in private practice, that's going to be more difficult. You have to collaborate with somebody and create, you know, kind of like what we were talking about, creating a center. You can create a center that's somewhat virtual, right? So you've got somebody doing work over here on this part of the diabetic foot, somebody doing work over here on that part, but it's about those connections between one another. And now, I mean, luckily, one of the benefits I think that came out of the pandemic was just the improvement in the way that we communicate with one another, or I guess the more opportunities we have to communicate with one another. I mean, not all this technology works fantastic, but you know, PADnet, for example, it existed long before the pandemic. I was in Des Moines, Iowa, when it was 2007 or so, when that was there, and already creating these connections between vascular surgeons and podiatrists. But you have those opportunities now to connect that way, and I think another thing, and I alluded to this before, but this really is important, is creating that sense of trust in the referral process that goes back and forth. You know, so if you're a podiatrist, you're watching this, you don't want somebody to refer you a patient urgently for something that's not urgent. You know, and if they don't understand what it is that you do, then your clinic gets clogged up with these non-urgent things just for screening. Oh, can you please just screen this person? But you had to delay all these other urgent people. That's not good. So you know, coming together, already agreeing and preferably putting them in writing, the referral process, how people, you know, which people are going to be referred urgently, how they're going to be referred, I mean, I mostly text the other people on our team, and hopefully nobody from the hospital is watching, because they say, oh, don't text anybody. But that's often the fastest way that I have to communicate with somebody. But there are a lot of ways to do it now, and I think those touch points on your team with immediate communication are super imperative.
One thing I want to re-emphasize about screening payment is that the Medicare does pay for AAA screening at a certain criteria. For peripheral disease. You have to your screening is actually the wrong word. When you have there are no pulses, the patient is symptomatic, or then it becomes an initial diagnostic test, and that's how the CPT codes you pay for the diagnostics part of it.
I believe that it concludes all the questions. Any last comments?
No, we have, thank you all for attending. I know that it's an evening and you take your time out to listen to this, and we will also obviously post it, and some people can hear it later on. But if you have any questions, please, we are very passionate about it. Please contact us. Both the biomedics is very passionate about finding vascular disease, and as a part of Apex, we are very passionate about taking care of these people. And creating systems in which we can save and preserve legs is good for people. Thank you.
Thank you, everyone.
Thank you.